Good afternoon. I have the great pleasure today to be able to moderate this breast cancer tumor board for us. We're going to discuss some very interesting cases, complex clinical decision pathways, and I'm honored to be joined by my esteemed panelists. I'm going to start with Dr. O'Shaughnessy, if you would like to introduce yourself, and then we'll just jump right in. Dr. O'Shaughnessy.
Hi, I'm Joyce O'Shaughnessy. I'm a breast medical oncologist. I work at Baylor University Medical Center, Texas Oncology, and US Oncology in Dallas, Texas. Real pleasure to be here with everyone.
Hi, I'm Tom Buchholz. I'm the medical director of Scripps MD Anderson Cancer Center in San Diego, and I'm a breast cancer radiation oncologist.
Hi, I'm Rennie Butler. I'm an associate professor in the Department of Diagnostic Radiology and Biomedical Imaging at Yale. I specialize in breast imaging, and I'm delighted to be with you all.
Dave Mamones, a breast surgical oncologist. I work at Orlando Health Cancer Institute. I direct the breast program there.
This is a 65-year-old Caucasian female with a history of stage 2A, sort of ER low, if you will, between 1 and 10% positive, PR negative, HER2 positive, right infiltrating ductal carcinoma. She was treated with neoadjuvant pertuzumab, trastuzumab, docetaxel, and carboplatin, followed by mastectomy with sentinel lymph node biopsy and seed localized axillary lymph node removal. And the clinical question that is being posed is, could treating the axilla with radiation instead of an axillary lymph node dissection be considered given the low residual nodal burden following neoadjuvant chemotherapy? So we will move forward with some more details about this case. So she presented with right breast pain and changes of the nipple in October of 2020. She has an excellent performance status, medical history only significant for hyperlipidemia, gynecologic history significant for menarche at 11, menopause at 52. She is G2 and P2, no breastfeeding, oral contraceptives, or hormone replacement therapy. She smokes 5 cigarettes per day and uses alcohol socially. Family history, no breast cancer history, but father with colon cancer at age 70. In November of 2020, imaging evaluation with bilateral MRI, and it should be noted that that was done initially because the patient initially refused mammography. The MRI demonstrating a 1.6 by 1.4 by 1.5 centimeter mass. And I apologize, we'll go back here. Maybe we'll just go ahead and let Dr. Butler, if you want to walk us through some of these images.
Sure. Her mammogram, which we see in the center, essentially almost perfectly mirrors her MRI on the left. They both show a spiculated mass in the subareolar region of the right breast, and that mass extends anteriorly toward the nipple, where we see it retracting the nipple. On the ultrasound of the right axilla, all the way on the right, we see a very abnormal appearing lymph node morphologically. We normally look for the bright center that represents the fatty hilum in a normal lymph node. In this case, it has been almost completely replaced by tumor cells.
Perfect, thank you so much. So biopsy of that axillary node confirmed the presence of metastatic carcinoma. She had a right stereotactic core biopsy, which showed a grade 2 invasive ductal carcinoma of similar biology. So she completed neoadjuvant pertuzumab, trastuzumab, docetaxel, and carboplatin. No post-treatment imaging was performed. She was clinically node negative by exam, so a good clinical response to the neoadjuvant chemotherapy and targeted therapy. She had a right mastectomy with sentinel lymph node biopsy and seed localized retrieval of the clipped axillary lymph node. And I might have just Dr. Menounos, if you might comment for us at this point about this surgical approach, given the initial positive node and then clinically converted to node negative, and the decision to move forward with sentinel lymph node biopsy. Your thoughts about that?
Yeah, so over the last few years, I think there's been considerable progress in terms of applying less extensive surgery in the axilla for patients that have a good response to neoadjuvant chemotherapy. We demonstrated that even the patients that had positive lymph nodes before, that become clinically non-negative and have a sentinel lymph node biopsy that is negative, the false negative rate of the sentinel lymph node is slightly higher than the upfront setting, about 12 to 13%, but certainly appears to be safe and effective. But another development is the development of identifying the clipped lymph node that was biopsied before neoadjuvant chemotherapy, in addition to the sentinel lymph node biopsy, removing that clipped node. And that brings actually the false negative rate to the about 5 to 6% range, which is essentially almost better than we had with upfront sentinel lymph node biopsy. So we feel that this approach is actually very safe, and we'll call this a targeted axillary lymph node dissection. Now, if the sentinel lymph node is negative, we feel comfortable to not complete the axillary dissection for such patients. On the other hand, if the sentinel lymph nodes are still positive, then the standard of care is to complete the axillary dissection, because there is high likelihood of having additional positive non-sentinel lymph nodes. A large study from Sloan Kettering showed about 63% range, either if you had micrometastasis in the sentinel node or if you had macrometastasis. Isolated tumor cells, though, in one sentinel node is kind of unique situation, because technically the node is negative, although there is the few cells in the lymph node. In the same Sloan Kettering study, patients that had isolated tumor cells in the nodes had about a 17% chance of having additional non-sentinel lymph nodes. So technically, this patient has negative nodes after neoadjuvant chemotherapy, but as the data have shown us, minimal involvement of the nodes after neoadjuvant chemotherapy doesn't have the same prognostic value that has upfront. In other words, what it's telling us is that having even microscopic disease in the sentinel nodes portrays potentially more disease in the non-sentinel nodes. So to make a long story short, for this patient is a little tough situation, because he only has one sentinel node that had isolated tumor cells. So I would not be terribly uncomfortable with radiotherapy, as Dr. Bajos will allude to in a minute, and not completing the axillary dissection. But also, you could say that with about a 15 to 20% chance of having additional nodes, since we don't have data on the efficacy of this approach to do it. But I would actually not feel very uncomfortable not doing it and proceeding with radiotherapy.
Yeah, I agree with Dr. Mamunis that the isolated tumor cells might reflect something different in a treated lymph node versus an untreated lymph node. There are, as you know, 2 randomized ongoing trials in the post-neoadjuvant setting that address the optimal local regional therapy. For people who are lymph node positive who convert to lymph node negative, there's a randomization between how extensively we should use radiation of the lymph node. So either yes, no to post-mastectomy radiation, or if they treated with breast conservation, yes, no to regional lymph node radiation. And then conversely, if the residual node continues to be positive, then they're randomized to completion axillary dissection followed by radiation, or just using radiation alone, kind of like the Amaros trial was done in the non-neoadjuvant setting. I think with this case, I would be inclined off protocol, outside of the context of a clinical study, to use radiation and use post-mastectomy radiation. And that would be addressing regional lymph node irradiation as well. And so I think one compromise in this would be to not do an axillary dissection and use radiation of the regional lymphatics, because we'd probably be wanting to have radiation incorporated into the component of her treatment anyway.
Dr. Mamunis, do you kind of agree with that approach? Is that how you would end up?
Yes, absolutely.
Perfect. So in summary, given that we would want to utilize post-mastectomy radiation for this particular patient, it seems that additional axillary surgery could be avoided, and she could just be treated with adjuvant radiation therapy. We'll take a slight deviation on a similar case. This is a 54-year-old Caucasian female with a preoperative diagnosis of ductal carcinoma in situ, now status post-mastectomy with 3 foci of grade 3 invasive ductal carcinoma and 10 foci of microinvasive ductal carcinoma, ER/PR negative, HER2 positive, with 0 of 1 lymph nodes involved on final pathology. And the question that is being posed is, does this patient require adjuvant chemotherapy for the small ER/PR negative, HER2 positive breast cancer? So Dr. O'Shaughnessy, do you want to comment about that? Maybe before that, we'll let Dr. Butler show us some of the pertinent images.
Sure. Very quickly, what we have here is a left LM view on the left, and on the right of that, we have the same view, but with a magnification paddle. In spite of that magnification view, it may be difficult for our viewers to appreciate the very tiny calcifications that we see in this breast, which of course are the types of calcifications that we term microcalcifications that we worry about. But if we could view this on a workstation, I think we would be able to appreciate a large region of multiple, innumerous, really, tiny microcalcifications in the left central breast here.
Thank you so much. So Dr. O'Shaughnessy, back to you. What are your thoughts about this patient's adjuvant treatment given the very small ER/PR negative, HER2 positive breast cancer?
Well, I'm a little worried about the biology of this breast cancer with 3 areas of invasive disease. We're not sure exactly how large they are, but even if they were sub-centimeter, that's still 3 invasive areas. And then with 10 additional areas of microinvasive disease, this is a highly invasive cancer. And I certainly would recommend adjuvant therapy. She's node negative, so I would likely not utilize the pertuzumab, but I would utilize trastuzumab. One could consider weekly paclitaxel for 12 weeks with trastuzumab, but with the biology and the extent of disease, I would actually favor more of a docetaxel, carboplatin, trastuzumab regimen for her. Whether I would do 4 cycles or 6 cycles would probably depend on the extent of the invasive disease. If it was sub-centimeter, I might be comfortable with 4 cycles, but if it was over a centimeter, I'd probably go 6 cycles of the TCH.
Perfect. Okay, so just to summarize for this patient with very minimal amount of invasive hormone negative HER2 positive breast cancer, we would favor adjuvant systemic therapy with trastuzumab based treatment, either with paclitaxel trastuzumab for 12 weeks based on the APT trial, or with trastuzumab, carboplatin, docetaxel, a traditional more TCH kind of regimen with 1 year of anti-HER2 therapy.